it's expert panel discussion on challenges and pitfalls in the management of osteoporosis. And for this expert panel discussions, we have 3 renowned speakers today. So I would like to invite Dr. Vivien Lim, and then Professor Sarath Lekamwasam, and Dr. Jayaprakash Sahoo to come to the stage. So the CVs will be displayed. Now we are going to go move with the session. And for this, we have formulated some interesting cases with osteoporosis so that we can cover some of the key points. So I would like to give Maulee the mic.
Can we have some more mics? It would be easier. So we'll move on with the case scenarios. So this is a 71-year-old lady who was evaluated for osteoporosis. So she was menopausal since the age of 50. She was relatively in good health with well-controlled hypertension, managed with amlodipine. There was no past history of fractures and no family history of osteoporosis. So she was thin-built with a BMI of 18. So these are her baseline DEXA scans. So you can see there's a bit of a scoliosis there. And in the lumbar spine, the T-scores are, if you could appreciate it, there's the total is minus 2.7. And in the hip, there's the femoral neck, T-score of minus 2.4 with a total hip of minus 1.9. So her baseline investigations, which include her normal full blood count, ESR, renal, liver profile, thyroid function tests, calcium, vitamin D, they were all normal. And therefore, she was commenced on oral bisphosphonates, weekly alendronate with adequate calcium and vitamin D. And she was re-evaluated. And next, we see her in 5 years. Let's see how the situation is now. So there has been no any additional risk factors. And she has been compliant with her medication. There was no fractures or back pain. Though there's a height loss of 155 centimeters. That's a 3 centimeter loss from her previous. And in the X-ray, because there was a 3 centimeter loss in the height, she underwent an X-ray scan to rule out any wedge fractures, and there were none. So she underwent a repeat DEXA scan, and this is the summary. So you can see that from 2018 to 2023, there's a change in the BMD. The percentage change is 2.1, which is keeping with the least significant change. And however, in the left hip, there's a decrement in the BMD from 2018 to 2023, and the percentage reduction is 9.6. So I would like to ask Dr. Vivien Lim a little bit about the interpretation at this stage and how we are going to move forward. I know you're having another lecture after lunch where you can elaborate more, but in terms with this case.
Well, thank you very much then, and to give me this case, because it's like a teaser for my post-lunch talk. Can I borrow the clicker? So how do I go backwards? Backwards is...
Oh, this is the pointer. You need the pointer?
Oh, I need a pointer and the clicker.
Yes, this is the pointer.
So, if you can help me when I ask you to go backwards. Okay, so to interpret this bone mineral density first, right? You're asking me to interpret this. Okay, so if you take a look here, first off, I have to say, well, there's an article by the prevalence of your obesity in Colombo. If you take into account abdominal obesity and above, that's 80% and above. This is a rare unicorn. Seriously rare unicorn. She's 1.58 centimeters. She is 45 kilograms. BMI of 18. Are you sure she has no secondary cause of osteoporosis? This is here. So that's number one. Is there something else going on? Okay, but let's say I take it as face value, nothing else going on here. Then number two, you said that you treated with bisphosphonate, you gave her adequate calcium and vitamin D. And then when, if you go to the next one, right? Yes. And then you looked at the BMD change, and against baseline is 2.1% in the spine, but there's this huge drop in the hip. Now if you go back again, sorry, let me show you something. This is the first one, yeah? When you use this, I'm jumping deep into discussions about this really. We will start from the basics later on in the talk. So if L1 to L4 are used, if you look at the standard deviations of the T-score, I use the total to tell me that this is osteoporosis right from the very beginning. Look at the wide variation in the T-scores. You should never actually use anything which is more than minus one standard deviation. If you look at this, sclerosis, only this actually may be less sclerosis. I can't use only one lumbar spine to gauge my T-score. So therefore, this is actually abysmally low, but this is probably the best of the lot to decide what the actual bone mineral density T-score is. So to keep that in mind, that this might be artificially increased. So it underestimates the risk already. Number two, this is an ugly looking spine. This is hip. It has to be internally rotated enough. So this is not internally rotated enough. The lesser trochanter is huge. It should be a sexy little bump. So number one, so when you have decrease in lesser rotation, internal rotation, what happens is you again underestimate the T-score. That's why you have total, which is minus 1.9 and minus 2.4. Now if you go to the next one, this. So now if you compare 5 years later, what am I exactly comparing? 5 years later, sclerosis will be more already. Is this a true estimate? And number two, when you compare, you are not supposed to compare the T-scores, you're comparing this. If you do a hemoglobin 2 settings apart, we generally use about 1 gram per deciliter to decide that there's a real change. If you step on the weighing machine, you're going to go 1 kilogram, you're 0.5 kilograms. That's not a real change, is it? So 2.1%, not a real change. I can't get 2.1% even in the best of institutional centers. I'll probably say about 3%, so that's number one. And if you increase, it might generally be also, again, an underestimation because the sclerosis has made it even higher T-score now. So I'll take that with a pinch of salt that there's a real increase. Number two, in the DEXA score, they didn't show me the second bone mineral density of the hip. So if the hip now suddenly decreases, you suddenly measured it better. You internally rotated it better because the technician is clever enough to do the internal rotation. Immediately, if you did it on the second time, you would already see that it's lower. An optimal internal rotation would give you the lowest bone mineral density. And now if you do that already, so maybe it was better. Maybe they optimally rotated it better. That's why it shows that great drop. So I'm not sure whether this is real. Let's take it that this is real. Suboptimally measured T-score, suboptimally measured hip scoring of the bone mineral density against a suboptimally measured one, you will get, if you get this drop, would this be real? Yes, it's real. Because in institutions, generally I would expect 6% in terms of to say that there is a real decrease in the bone mineral density. So I will accept that, yes, this is real. Would that be, that's your question, right? To compare the bone mineral density. Yes. So I'll shut up now and then listen to your next question.
So after evaluating Dr. Lim, what kind of treatment, how would you think that best we can manage this patient?
So now we're going to management part, but before I go into management, remember this is a rare unicorn of a woman in Sri Lanka, right? In which the BMI was 18. Look at her BMI now. She's 37 kilograms, a BMI of 15. If she was rare unicorn there, I don't know, this is a super rare multicolored unicorn with 2 horns, yeah? So there's something else going on here.
It is a real case.
Yeah. That's why, given that I also have passion in obesity management, weight management, to get this, do you know how much deficit in energy, that's in the debate, do you know how much decrease in deficit in calorie deficiency you will have at 71 years old, and now she's 76 years old, to lose that amount of weight? She will be taking, you need, over that 5-year period, right at the very beginning when she was 45 kilograms, she would probably need about, and 71 years old. Sedentary, she will need about 1,000 1,100 calories a day. To become 37 kilograms in 5 years, there will be a deficit of that from that 1,100 calories consistently to lose that amount of weight. Now, I don't know how long she took to lose that amount of weight. To have that happening, please check whether she has another cause. So secondary causes is not just your typical one. So I like this case because if she's depressed, is there something else going on? Does she have cancer? Is she not eating? What's happening? Is she gastroparesis? Is she having malnutrition? Something is going on with her. Whatever drug you give her, I cannot fight a weight loss. This is a starvation diet to get to BMI of 15. You first have to protect your brain, your vital organs, before you protect your bones. So whatever I throw at her, I cannot fight that weight loss. See, now that's number one. Number two, well, I have to throw something at her, right? It's just like the testosterone metformin was a poor man's a thing for PCOS and hypogonadism, functional hypogonadism. So it's better to have lifestyle. Number one, go for lifestyle. Number two, if I have to change, I'll give you a poor man's one. I will change to denosumab. Why? Because for bisphosphonates, we already know the data for the spine. It does increase the spine, but not as fast, not as much as a denosumab. With regards to the hip, after 3 years, data is already flat. So it's not going to move anymore. It will plateau regardless of what. This is not the same that it does not have fracture decrease. But with regards to, let's say, treating to a target, it's not so good for the hip. Now, if she lives in a place where there's poverty, where your only thing is a bisphosphonate, please do not stop and please continue. If she has if she's in the optimal treated center with no issues with financial, then I would change to denosumab. Because at least for the hip data, it does not plateau. It can keep on going higher. So that's one thing. So please rule out secondary cause. In this case, please lifestyle change, increase the weight. And then, yes, I would change, if we are able to, I would change to denosumab once in 6 months.
Okay, now, Dr. Lim, the availability of denosumab is very scarce here, so we mainly go with the bisphosphonate. So if it's starting a bisphosphonate, what would you recommend? Do we need to go for zoledronic acid, or would you prefer an oral bisphosphonate?
Okay, so if, let's say I saw her in the beginning and you start with a bisphosphonate, it also depends on whether she's of course in the community walking and she can follow instructions. Oral would be, again, if you're talking about finances, oral would definitely be cheaper. And a lot of times in the public sector, out there in the primary health care, they should have an oral once weekly bisphosphonate. And most of the time it's generic alendronate. So I would start with that. As another thing is that if you're 71 years old, also calculate the GFR. So if you're going to give zoledronic, if the GFR on calculation, especially she's so low, muscle mass so low, is actually lower than 45, you might be careful about giving zoledronic.
So regarding the weight loss, because you raised several questions, so can sarcopenia play a role here? I mean, again, another important thing, she's a patient with past history of polio. Polio, yes.
Sarcopenia, she would already have had that at 71 years of age.
Yes.
Unless she's doing a marathon. If not, her estimated calorie intake when she's sedentary is 1,100. Why would she still keep losing? I challenge anyone here to take 1,100. Good luck with you. 5 years, consistent. She'll have to take consistently 5 years, about 1,000 calories to 1,050 calories per day. So if you think about that logically, how would polio make a difference? It doesn't matter what she has. Calorie deficit is calorie deficit. So something else is going on with her. Why is she not eating? Why is she still consistently? She says she is. The weight does not lie. It's just like if someone or my patients will always tell me, I eat very little, I eat very little, I eat very little. Same age, 3 times her weight. 37 times 3, 1.58 is not unreasonable. I see so many of them in my clinic. I also see people like her. That's why I know. Which one do you believe? You believe logic, which that you know that she's 1,100 calories a day. I give you 1,500. Not possible, not possible, not at 45 kilograms. She lost from 45 to 37. Something else is going on. Yeah.
Thank you. Would the other speakers like to contribute?
So when it comes to ruling out secondary osteoporosis, particularly in the patient having BMI is very low, sometimes we can rule out like celiac disease. So we have seen few cases of celiac disease where there may not be any obvious GI symptoms. The only presentation will be a decreased BMD. And the most important thing is, unless you will take care like celiac disease, whatever treatment will give, the BMD may not increase. So I would like to consider obviously secondary osteoporosis, and in this patient, particularly low BMI, celiac disease can be one differential diagnosis.
One thing I'll be a bit concerned about is that about the little bit of technology of the BMD estimation. And the BMD estimation, because, just not to go through a lot of details on that, the software that provided by the manufacturers is generally for the standard body weight. And then if you want to assess the BMD of a, let's say, very lean person, and then there are different software that should be used. So if you use the standard software for a very thin person, and your bone mineral density can be erroneous bone mineral density that you can get. So here also that I would be little concerned about the accuracy of those bone mineral density estimations, whether they are real values, because in a very thin person, and bone mineral density estimation become real nightmare. As she said that, because the loss of bone mineral density 9.6% in the hip is probably because of the rotation, because in the first scan, you can see lots of greater trochanter, and indicating that it has not properly rotated. And then in the spine, it does not beat what is called least significant change. And with, let's say, if you got a precision of 1.5%, that is usual machines have, and then the least significant change come to about, let's say, 5% to 6%, like so. It has not actually beaten. So there's, although you see 2.1% change in the bone mineral density in the spine, and that's not actual real biological change difference, really. That cannot be taken as. So I go along the recommendation that she should be investigated further to find out whether she has got underlying disease. So that needs to be done.
Yeah, so one other question, Dr. Lim, is now with denosumab, there's a concern that once you stop it, there's a good BMD decline. So if you are going to start denosumab, how long would you plan that treatment?
For her, forever.
Right.
Look at her spine. Can you go back to the spine? As I mentioned, really sclerosis. This, because I cannot conventionally use L1 or one vertebra alone, I would be estimating she is very high risk. If I assume that everything is optimally monitored, she really dropped 9%. And I actually do believe, because she dropped from 45 kilograms to 37, and I feel that there's something going on with her truly. So for her, she's 71 to 76 already. I would treat forever. So for her alone, there would be no issues about stopping. And even if I stop, let's say miraculously, it became wonderful, and it's minus 1.5 in the total hip. Okay, so in that case, I could then switch to bisphosphonates. I mean, this is all controversial. Each of us has our own way of doing things. I might switch to a bisphosphonate, go on for another 3 years, stop. Because only in the bisphosphonates can I go for a drug holiday, because it has that weird little characteristics of happily going into the bone, and then over the next few years, it will slowly permeate out. It's still running around in the system. So I could do that. But that would be a happy occurrence. I wouldn't worry. I'll just keep continuing.
In a Sri Lankan scenario, Professor Lekamwasam, what would you know about the denosumab?
Yeah. That's really a nightmare, because we got plenty of these patients, every now and then, and the problem is that they have partial response to bisphosphonate, but they have not got into what I call the target, treat to target, the targets that they have not achieved. So you are unable to discontinue bisphosphonate. need to continue with something, but then something becomes, denosumab generally, but then because our options are very, very less, because denosumab is not readily available. So these people were compelled to continue bisphosphonate and while keeping an eye. I would rather give her a bit of solidronic acid, as she said that her weight is low, and then you need to adjust that. So if the renal functions are normal, and maybe that you can try a half dose of solidronic acid maybe for 3 years, and then reassess her and see. However, I must say that, because the bioavailability of the oral bisphosphonate is very, very, very poor. And so there are people who do not absorb with a very good compliance, although they have good compliance, they do not absorb that much bisphosphonate from their system and into their system. So I think probably think of denosumab in local scenario is no one will blame you for doing that.
Thank you. A little bit about calcium and vitamin D, because that also plays a big role. What are the doses that you would recommend for vitamin D? Because sometimes the guidelines do say it's 800 to 1,000, but then sometimes clinicians tend to go above that, assuming that the vitamin D levels are normal. So for a maintenance therapy, what would be the doses that you would recommend for vitamin D and calcium?
Okay, first off, different people have different guidelines, and so I would say follow the local guidelines. But also use judgment call. This is a person with osteoporosis who has dropped already. Okay, we believe all that she has dropped her BMD already. So I need to treat an osteoporotic patient. You customize with this patient. She dropped her BMD, she dropped her weight. She's not eating enough. How much if she can drop her weight like that, how much calcium you think she's taking? In Singapore, we have National Nutritional Survey, average of about 720, 730 milligrams per day is what a person takes from the diet. So you need to know your Sri Lanka Nutritional Survey. How much is the mean? But mean is mean, average amount of intake from diet. Of course, I want it diet best rather than supplementation. But let's say if it's her, how much do you think she's taking? Hardly any. So if I need 1,000 milligrams a day, in general, international guidelines would go about anywhere between 800 to 1,200 milligrams a day. Then I would supplement her. The best case scenario is she takes, if she can take milk and lean, for example, calcium fortified, calcium enriched milk 2 times a day, that will give me 1,000 milligrams. Or soya milk enriched, that will be 1,000 milligrams. So that's great. So you build her calcium stores, you can give calcium, and at the same time, you gave her calories, and so she can increase weight, hopefully. If you can't do that, then you have no choice. You would have to give calcium. And you have you need to give elemental calcium. So be careful when you're giving a supplementation. Please look what is given as. If it's calcium carbonate, 1,250 milligrams, that is not elemental calcium. Elemental calcium is 40% of that. So elemental calcium is only 500 milligrams. So be careful what you're giving. Sometimes they're going calcium something else. And the calcium, the elemental calcium is only 10% of it. So you're not going to give enough of that. So to be mindful of that. Vitamin D, for bone, is 30 nanograms per ml and above. So for the rest, I mean, of course, there are many, many things when it comes to vitamin D. Some people want 40, some people want 50, but the bare minimum would be 30. For her, I would make sure that she has enough more than 30. So then you would have to, unfortunately, do vitamin D assays, which is also notorious to be different between different institutions, to see whether you are adequately replaced her. I would go according, I mean, with what I do in my practice would be, I would measure the vitamin D, and I would use that to adjust how much I've given. Sometimes, especially for South Asian, because the Fitzpatrick skin, you do not efficiently, especially if you grow older, produce vitamin D in the skin. So I have given up to a lot, 50,000 units per week, sometimes 100,000 units per week, just to give me a vitamin D of 40 nanograms per ml. So, I mean, I've seen that happen, but absorption might be an issue. That's one thing. So different people have different absorptions, and also in terms of how much it can actually increase it.
So I think we'll move on to the next case. Yes, so here we have a 84-year-old female referred by the orthopedic team. So she has a background history of hypertension, TIA, and peripheral neuropathy. She's been menopausal since 50 years of age. There's no obvious secondary causes for osteoporosis, and she has had a history of recurrent falls. So she was diagnosed with osteoporosis when she was 68 years old, and at that point started on alendronate for 5 years. She was given a drug holiday for 2 years and subsequently started on alendronate for 2 years again. Then she went on to develop a femur fracture on the left side, which required surgery, and somehow in that event she had defaulted alendronate, and then it was restarted after about 2 years, and she was on it for 3 years, and after that she developed a femur fracture on the opposite side, which required surgery, and at that point, and also subsequently, after a few months, she also developed a T8 compression fracture in the vertebra. So then she was referred to endocrine clinic, and subsequently at the clinic we had started on denosumab. She was given 2 doses, 6 monthly, and the third dose, while awaiting the third dose, she had a bit of a delay, about 3-month delay in the third dose, and in the interim she got another fracture. So these were her scans in 2018. By that time, we don't have her initial scans, but by this time she already had been on alendronate for 7 years and had developed a left hip fracture. So so you can see, again, a horrible spine, so obviously severe osteoporosis. And this is the basic summary. So from 2007 to 2018, she had been on alendronate for a total of 7 years, developed a left hip fracture, defaulted treatment, and in 2018, again, alendronate was restarted, and you can look at the BMDs. So subsequently, the BMDs in the spine had been more or less same without any BMD change. But because she developed a right femoral fracture in 2018, then since both the femurs were fractured, then we had to monitor with the forearm. So you can see there from 2018 to 2021, 2023, there has been a reduction there as well. And if you take the forearm, there has been a minus 9.6 change in the distal forearm. So her other investigations, including the baseline bloods, full blood count, ESR, renal kidney functions, thyroid profile, they have been normal. So the total calcium, the phosphate was normal, as was the vitamin D. The PTH was slightly high. This could have been probably because she had been on long-term bisphosphonates as well. So here we have an elderly lady with multiple fractures who has been on bisphosphonates for 10 years and now on denosumab, and the recent most fracture while on denosumab. So how would you from here on take it on, and what are we going to do at this situation? I would like Prof. Lekamwasam to answer.
Thank you, Maulee. And thanks for giving a typical geriatric MD long case. There are many issues in this patient because she's 80 years old and she has got multiple fractures. There are a couple of issues that you need to remember when you're dealing with the 80-year-old patient who suspected osteoporosis. This is one of the clinicians kind of, a nightmare. Now, first thing is that the bone mineral density that you measure may not be, again, as I said, erroneously changed, because there are multiple, what I call the artifacts that you find in elderly people, and osteophytes, the calcification of major arteries, and they all add to the calcium. So as a result, the calcium the bone mineral density may not be the accurate values that you see. The second issue is that when you are calculating what's called the fracture risk of an 80-year-old person, and certainly the FRAX would underestimate the fracture risk, because the FRAX is built on what is called the, apart from the fracture data, apart from the, let's say, age-specific fracture data in that particular country, and it utilizes what is called the mortality data. So age-specific mortality data. So in that particular country, if the people of 8 years, I mean, the life expectancy is about, let's say, 85 years, and the FRAX would consider this patient would live for another only 5 years, and then the FRAX-based fracture probabilities would be low, and that would not reflect her real fracture risk in that estimation. Other thing to remember is that these people, 8 years, the fractures are, well, BMD contributes, there's no question about it. But then there are many other factors, like let's say a frailty. A frailty is one of the major problem of these people, because the frailty leads to a multiple, what's called recurrent falls, and the recurrent, however much, whatever the treatment that you use, whether it's denosumab or it's a bisphosphonate, and these people will fall. And as a result of falls, and they will fracture. So unless the clinicians are aware of what is called the possibility of having a frailty in this patient, and then the assess risk of falls and try to do something about the falls, and then none of this treatment is going to work for her. You can see that she had fallen and fractured one side, and 2 years later she has fallen again and she has fractured another side, and again she has had fallen. So she probably had recurrent falls, and every time she falls, she fractures something. So, and also you see that the bone mineral density, the DEXA scan, her bone mineral density is in the range of -4, I think is somewhere there, and the bone mineral density is very low. So in the management of this patient, what I do is that she needs a comprehensive geriatric assessment. Need to look at her drug treatment and see whether there are drugs which can cause recurrent falls. And also that I think she has a TIA and also peripheral neuropathy, and we have very, very well-known causes of recurrent falls, and also they need to be looked at very carefully. So she needs a geriatric assessment and find out alongside the bone health, and someone need to assess her risk of falls and see what you can do about them to either minimize falls, the number of falls, or prevent them. So that's number one. The nutrition, exercises, balance training, and generally frailty is tackled with multiple things, like not only just one component in the management. That is a combined treatment. Generally you go for nutrition, physical treatment, and then balance training and all that. And the modification of treatment, prevention of polypharmacy and all, they all are very important. As far as I see her, at the time that she came with 2 fractures, one hip, both sides, and then with that bone mineral density -4, probably she is not a candidate for antiresorptives, because that bone mineral density is very low and risk of fracture is very high, and probably she's a patient for anabolic treatment. So at that point, well, instead of denosumab, whether you would have considered anabolic treatment for her. I know they both are not really available in Sri Lanka, I know that, and because you have to really struggle there. So whether choice would have been anabolic treatment and instead of denosumab, because that will increase the bone mineral density much quicker than antiresorptives, and then to a certain extent her fracture risk would be less. That explains why she fractured again while she was on denosumab, at least 2 injections, and then fractured again. So in summary, these are problematic patients, and particularly with regard to the attack of the recurrent falls. And unless we do something about the falls and either minimize them and teach them how to fall safely, that type of thing, and then a drug treatment can do only very little, and they continue to fracture. So I think while you consider the possibility of the suitability of giving anabolic treatment, I think she needs a comprehensive geriatric assessment and see what we can do about the recurrent falls. That's one of the major component in the long-term management.
Yes, so if you are selecting anabolic therapy, what would your preferred choice, and how long would you treat this patient?
Yeah, first of all, that certainly you will struggle to find to get this drug, and then you certainly treat for 18 months. But again, I mean, there are many things to be monitored. Many things can go wrong during that period. So it is to get anabolic treatment. I think teriparatide would be the obvious choice. I don't think we have got anything more than that, access to anything more than that. And then while you are making sure that she take adequate protein. Get some kind of exercises, perhaps under the careful observation of physiotherapist, and then get plenty of, let's say, sufficient calcium and vitamin D, and then you monitor.
Dr. Lim, what about you? What sort of anabolic therapy? Do you have access to other newer forms of anabolic therapy?
Yes, I do, but can you move back to the previous screen? The previous one. Okay. One more thing. So if you look here, this is underestimation. Kill this away. You must be one standard deviation. By the time you come to my talk, you all know how to do this really. This is less than one standard deviation away compared to this, so you have to throw this away. The real true assessment is this. She has very, very low T-score for her spine. Okay, forget about the hip, but so this, you always take the lowest. If you move to the next slide for me. So that's one thing first. If you move to the next slide, take a note here. Look at your distal forearm fracture, distal forearm, which is a drop of minus 9.6%. You move on to the next slide. She has a secondary cause of osteoporosis. The PTH is 11. We have not scraped the barrel of secondary causes of osteoporosis here. So first off, ESR slightly high. I don't know, you didn't give me the upper limit, but this looks slightly high. Yeah, but she's elderly, could be that. Hemoglobin looks slightly low to me, even though creatinine is normal, calcium is normal, multiple myeloma, because we must scrape every barrel for her, because she has minus 4.5 on the T-score, and she keeps dropping and she keeps fracturing. So you must find that secondary cause. Multiple myeloma not done, do it. Second one, I would want to see talopeptide because I want to have an idea, a bone breakdown marker. Where are we now? That doesn't tell me anything if it's 0.3. But if it tells me 1, I know I must search even more. Number 3, PTH high. Why is the PTH high? Is she not taking calcium at all? Is she very little? What's the 24-hour urine calcium? Is she leaking it like crazy? That might be another reason why the PTH is high. Vitamin D is very, very borderline. I might want to pump it up to 40, 50, give her calcium supplements. Make sure that, let's see, if this is secondary PTH is high, it can still cause your osteoporosis to get down. And another thing that can actually also support the fact that she might have parahyperparathyroidism, secondary or primary, is because the distal forearm dropped. And we know that hyperparathyroid affects the distal forearm first. So she might also have, even though her calcium is normal, but don't be foxed. This could be normal calcemia, hyperparathyroidism. I think someone is going to talk on that later in the talks. So make sure this is not the case here. So I am not convinced this person does not have a secondary cause of osteoporosis. Find that secondary cause first. Because if you don't find that cause, you can throw anything at them, they are still going to continue to fracture. And if you looked at the amount that she has taken, right? If you go back to the first slide in which you told me what it was on, just some pointers there. So so the alendronate of 5 years, you go on drug holiday. I don't even know why she's on the drug holiday. She's minus 4.5. What is she going to reach at 5 years? I will never put her on the drug holiday because the risk of that atypical fracture is much, much, much less than the risk of the fracture. And that's what you're happening here already. There's a fracture in 2016. She might have be because she defaulted treatment with alendronate, so that's a double whammy situation. You have a T-score which is so low, and yet you defaulted, so of course you have that first fracture. Now, having a second fracture does not mean there's failure of treatment, but then you have third fracture. Okay, so certainly there's failure of treatment with the alendronate already. Is it not absorbing? Is it because she didn't really take it properly? Fair enough, we referred to endocrine, started on denosumab. First fracture, it doesn't mean that a decreased risk is 0%. Yeah, just like aspirin doesn't exclude all risk of getting heart attacks. So that second fracture might actually, that T12 fracture might not be because of a treatment failure. And when did you start this in 2022? It doesn't work that fast in terms of, it's only 1 year. So that's another supporting evidence that it might not be that there's failure of fracture. So if especially in a place when, let's say, you cannot get teriparatide, you cannot get romosozumab, which is the other one that I'm alluding to that you asked me, do I have anything else? Yes, I do have romosozumab in Singapore, and I could use that. But if we cannot have that, there's some hope there in the fact that after you have excluded the secondary cause, that T12 compression fracture might not be because of treatment failure. So if you have nothing else, continue on with the denosumab, but please find that secondary cause. There is something going on again.
How would you define treatment failure?
So treatment failure would be, first off, one might not be, but everybody gets slightly scared when you have a treatment and the patients are not going to be happy with you and you say, you promised me that this medicine is good and then I fractured now. Okay, so generally speaking, even so clinically, even if one fracture is not treatment failure, we would or might change, especially if we were on bisphosphonates. I would then just change to denosumab, no biggie, right? But true treatment failure would be maybe 2. The second one would be that it's within more than 6 months at least, or 6 months to 1 year of being started on that particular medicine. Actually, I will use 1 year. More than 1 year of being started of the medicine, then something happens, there's a drop in BMD, there's also a fracture. Then I would say, yes, this is most likely real, that this is treatment failure. Sometimes some of the guidelines would put in also the bone markers, but that becomes a little bit more complicated, yes.
Thank you. So we'll move on to the next case. So this is a 63-year-old postmenopausal woman with CKD stage 4, and she is referred following a vertebral fracture. So the medical history, she has hypertension, she's on antihypertensive medicines, and the investigations show that she is mildly anemic and the creatinine level is 2.6 with the eGFR of 29. The liver function, the liver functions were normal and the calcium was slightly low and the phosphates levels were little high. Yeah, so this is the DEXA finding. She has total T-score spine of minus 4.7 and the hip T-score of minus 3.2 in the neck of femur. So with that, I would like to ask Dr. Jayaprakash, now how can this patient be managed? And firstly, how can we differentiate whether this is osteoporosis or whether this is renal osteodystrophy?
Thank you for the question. So this, in contrast to the last 2 cases where the osteoporosis was basically primary, most likely, though we have kept few DD. So this case is clearly a case of secondary osteoporosis, because in the routine investigation, serum creatinine is high, GFR is 30, almost patient in the second stage 4. So when we are dealing with the case of secondary osteoporosis, so before going to the pharmacological treatment, we have to give importance to the management related to the underlying disease. So obviously any patient of osteoporosis, to prevent fracture, in addition to pharmacological therapy, already we have discussed the nutrition and physiotherapy, exercise are important. Plus in this case, we have to give corrective measure to the other factors, like in CKD, why the bone mineral density is affected and why they are having at the risk of fracture. The thing is, in CKD patient, BMD is not is a true reflection of the underlying bone status, because in addition to in the change in the quantitative parameters, there will be huge reduction in the quality of bone, and that is not being reflected in the bone mineral density. So even if they are having normal BMD, still CKD patient can have fracture because of decrease in the bone quality. So here obviously the patient has already fractured, so irrespective of the BMD, we have to give the treatment. So before going to specific treatment, so first we have to take care of the non-specific measures, like in CKD patients, there are 3 contributors for the decreased bone strength. One is decrease in calcium, and second one is increase PTH level because of secondary hyperparathyroidism, and that happens because of both low calcium and high phosphorus. And the third was decreased vitamin D, both the vitamin D parental form and also activated vitamin D. And the last one is my metabolic acidosis. So we have to correct these measures. First, we have to, already we have discussed, like we have to give adequate calcium and vitamin D. And plus, in contrast to the primary osteoporosis, we have to give, in addition, activated vitamin D. Either it is alpha calcidiol or calcitriol. Then the fourth one is, we have to give phosphate binder, because in addition to giving adequate calcium, vitamin D, unless you will correct phosphates, PTH will be high, that will also affect the BMD. So calcium correction, then vitamin D, then activated vitamin D, then fourth one is phosphate binder, and last one is the metabolic acidosis correction. After taking care of all these measures, then we will see whether this patient requires the specific treatment for osteoporosis. So the treatment of osteoporosis with fracture in CKD is controversial. Even few guidelines recommend we don't need to take T-score minus 2.5 for diagnosis of osteoporosis. Even we can take the higher threshold like minus 1.5 or minus 2 because of underlying decrease in bone quality for considering treatment. But the patient has already fractured, so forget about the BMD, so you have to treat. So, but the problem is here the GFR is just 29. So the next question comes, which drugs, whatever drugs we have already discussed in the last two cases, which drugs we can give safely to a patient with GFR less than 30, that is in the end-stage kidney disease. So this is a gray area, there is no clear-cut guidelines, but obviously like treatment of primary osteoporosis, we have two options of treatment. One is anti-receptive and second one is anabolic. So in CKD patient also we can consider both types of treatment. So that will depend on the PTH level. So here I think PTH report is not there. So first thing is we have to do PTH level, and if the PTH level is more than 200 picogram per ml, obviously we'll consider it as a high bone turnover disease. But obviously the gold standard is the bone biopsy that is not available in most of the centers. So if the PTH level is more than 200 picogram per ml, so that means it is high bone turnover disease. So anabolic drug like teriparatide will not consider the first choice because already the PTH is the higher side. We can consider anti-receptive because GFR is just 30 and already Madam has told below GFR 44 we should be careful before giving zoledronate acid. But there are few studies support ibandronate can be given safely like up to GFR 15 in contrast to other bisphosphonate that we can consider. And if the PTH level comes less than 200 picogram per ml, that means low bone turnover disease. In that case, here in the background history of fracture, we can consider teriparatide.
Any other comments or?
You know, go back to your first slide. How old is this? How old? 63. Yeah. So. You go on. She's 63, she's stage 4 CKD. You look at her T-scores. So again, you minus 3.4 throw away, minus 4.1 throw away. She's minus 5.2 to minus 5.5. Osteoporosis is very common, 15% in patients between 60 to 70. Just because there's a CKD there, I wonder whether there's another cause, another secondary cause. So I would look for another secondary cause and not just blame it on CKD. Because I have a lot of patients who are GFR over 29. Nothing, yeah? So what to give? Denosumab, no issues. Not contraindicated at all. In fact, for this group of patients, the GFR, which is 29 one, denosumab I can give quite confidently and happily. I start getting worried about renal osteodystrophy when it goes to 15. Then my renal physician needs to come and discuss with me. So when we discuss, we will need the C-telopeptides there, the PTH, the calcium phosphate, and to see then have a proper discussion, what do we think? Is this adynamic bone disease or is this hyper? Right, so if it is, I have no qualms in giving denosumab. Just to be careful that when I'm giving denosumab, for the patients where CKD4 patients and below, the GFR, the lower they are, there's a higher risk of hypocalcemia. So that's something to look out for. Sometimes different practices are different. You might want to give a bit more calcium for whatever it's worth. Sometimes people give calcitriol as well in the first 1 or 2 weeks, because when you give denosumab is given to actually treat hypercalcemia and malignancy as well, although they're given 120. So they're very good in dropping the calcium, and you might see this calcium drop more in people with lower GFRs. Yeah. So.
Is there any concern with vascular calcification with denosumab? Is there any?
No. For us?
For the CKD patients?
No, I'm not worried because, so again, I'm an endocrinologist dealing with GFR of 29. If we are talking about 15 and below, that's a different kettle of fish. And truly to differentiate between whether adynamic bone disease or not, you need a bone biopsy. But that is so rare and so difficult to get. We don't have it in Singapore. I know that's there in the Mayo Clinic, and even the American centers, not all centers actually do that. So if that's, let's say, Holy Grail, we throw that away. Clinical practice, I only start getting worried as the GFR gets lower, not at 29. 29, very comfortable, not an issue.
Thank you. Right, so in the interest of time, I think we'll have to end the case discussion, but if you all have any questions, the floor is open. You can ask from the experts.
Okay, so, okay, sir, go ahead.
Just not actually a question, rather comment, like, because thing is, I know that we have issues in terms of, economic crisis and all these things, but there is a group of people who needs quite advanced therapies, and particularly we see the effect of we sometimes use in certain selected patients who can afford anabolic therapies as well as denosumab. And also sometimes when it comes to quality also matters. Sometimes the good quality products give quite impressive results. So I think we all need to work on these areas where we make available good quality medications, as well as at least try to pursue the availability of therapies so that those who really deserve, like these cases where the T-score is minus 4.55, we see sometimes when you give anabolic therapy, this will improve to 2 in 1 year. So these sort of things we all need to perhaps work together.
Yes. Hello, yeah, thank you for the great discussion. My name is Dr. Muhammad Ali. I'm from Maldives. So I'm a physician. So we see a lot of these patients having severe diseases tend to admit in ICU. What do we do with the drugs, like weekly medications? What do we do with it? We continue with it or stop it? Or sometimes we keep the patient for around 1 or 2 months on ventilator, post-ventilator. Maybe they stay, maybe they're waiting for home arrangements or something like that. Maybe 2 or 3 months they stay. What do we do with it? What's your experience?
Can I change to IV Zolidronate? If your weekly is oral, right? So if your GFR is not dead yet, change to IV Zolidronate. That's your 1 year done.
Can we start it during this admission?
Oh, you want to start it?
I mean, if it not already started, like if the patient is already on and the patient becomes sicker and goes in ICU admission, suppose, or maybe other admission in hospital, what do we do with it? Like, okay, already on the patient is already on like weekly Lendronate or monthly Ibandronate. Like, what do we do with it?
So if you remember, for the oral bisphosphonates, it's got this wonderful characteristics of being able to go into the bone and stay there for a while. You can even go on drug holiday in appropriate cases after 5 years and stop. Correct, right? So if that's the case, no problem, stop it. Just leave it as it is. But let's say if you're talking about that, so that's for temporary, one month. But if you tell me a patient is going on and on 2 to 3 months in ICU, the best case scenario, if you think she's still going to survive, being very practical, and the GFR is not an issue, IV Zolidronate, then you don't need to worry. It's 1 year.
Thank you so much.
Yes, so in the interest of time, I think we will need to wrap up. So I would like to thank all our wonderful speakers for sharing their knowledge with us at this very insightful session. Thank you so much.